Hello, I'm Dr. Loudon, and I'm going to be talking about decision making for radiation treatment for breast cancer. And in this presentation, we're going to look specifically at when a person had drug treatment first and then surgery, and where no cancer was found at the time of surgery. So, just to review that order of care, a person may have had chemotherapy with or without immunotherapy, or a targeted therapy if their cancer was what's called HER2 positive. They've completed that treatment and gone ahead and had surgery. And when the pathologist looks at all of the tissues removed at surgery, there was no cancer found in the breast and no cancer found in the lymph nodes. And the question is, well, should radiation treatment be given? And just to emphasize that we're going to look at a case where the surgery has been a mastectomy. So the entire breast is being removed and the pathologist has looked at all of the breast tissue. Let's take an example of a particular case that at the beginning, in the breast, there may have been one larger lump or there may have been a number of smaller ones. Importantly, we're looking at cases where the cancer wasn't what's called very locally advanced. It hadn't broken through the skin to cause ulceration. There weren't nodules on the skin that showed that the cancer was obviously infiltrating it. And we are looking at a case where the cancer was definitely proven in the lymph nodes, usually with a fine needle biopsy before treatment started, but where there wasn't a lot of nodes involved, that the nodes weren't big and fixed and all matted together. And we're going to look then at the breast being removed, and there was no cancer in the entire breast. And the pathologist typically will see in this kind of situation what's called a tumor bed, an area of fibrous tissue where we can infer that the cancer was once found, but there are no cancer cells left. And lymph nodes can either be removed with what's targeted or full axe theory dissection, or possibly what's called a sentinel node procedure, so that the nearest neighbors of the breast are removed and no cancer was found in any of those. And so this is what's called the complete pathologic response to neoadjuvant therapy. So to the question, should radiation treatment be given? Now, it turns out that the response of the cancer to that neoadjuvant treatment before surgery does help us to decide. Because what is the key issue? The idea is that we want to know how likely is it that there are still some microscopic cancer cells around, either in the chest wall, obviously those tissues weren't removed, in lymph nodes that weren't removed, or in the tiny tissue fluid channels that are tracking throughout the region. And if we believe that the chance is high enough, then we use radiation treatment to the areas of risk. And this picture shows the broad area of chest wall and regional nodes that is typically covered if the risk is thought to be high enough. And so the general idea is if the risk is high enough that you treat to add extra insurance that the cancer won't come back, and if the risk is low enough, then you don't treat. Now, over the years, guidelines have been developed. And if we were to look at relatively recent and still published guidelines, they basically would say if a person's had a mastectomy and this neoadjuvant treatment, that if the cancer was less than 5 centimeters at the beginning and there were involved nodes, that you individualize the treatment choice depending on the nature of the response to the drug treatment. But the guidelines also say that if the cancer is more than 5 centimeters with such involved nodes, go ahead and treat no matter what, because certainly at the time the guidelines were developed, the risk was thought to be high enough. Now, medical research moves along kind of one careful step after another. And as of June 2025, there was a recently published research that provides fresh insight, good quality data that, that refines guidance on that question whether to add radiation treatment. And I'm just going to go through that briefly. So patients involved in this study had a few involved lymph nodes. They didn't have big fixed matted nodes. And indeed, they tried to specify that there were no more than 3 detectably involved nodes. And importantly, these weren't cancers that weren't into the chest wall, ulcerating the skin, and so on. And the lymph nodes certainly, as I say, could not be bulky. But it was okay to have cancers that were over 5 centimeters in size. And when these patients had their surgery, there was no cancer in the lymph nodes. And they were randomly assigned that half of them had radiation treatment and half of them did not have radiation to the node areas. And if we look at the patients that had radiation, if they had a mastectomy, the chest wall was treated with radiation. But if they did not have radiation to the lymph nodes, they didn't have radiation to the chest wall either. So what was found? Well, the key finding was that the group without radiation did just as well as the group with radiation. So what that tells us is that a complete response to drug treatment predicts for a low enough risk that there are remaining microscopic cells that radiation treatment does not add value. And let's look at just a few other statistics details. First of all, how many patients in that study did have these bigger cancers over 5 centimeters? And turns out about 20%. So there are about 300 patients in that group, which is a reasonable size group. And to qualify for the study, you had to have a complete response in the lymph nodes. And how many had a complete response in the breast tissue that was removed as well? And about 80%. So this was a group that had a very good responsiveness to that so-called neoadjuvant drug treatment. And then the next thing is, if one of our endpoints is the probability of a recurrence in the chest wall or lymph node region, what was that probability at 5 years? Well, it turns out that over 98% of the study participants were free of any of that kind of recurrence at 5 years. So that's a very good result. And then lastly, what about the overall outcome of these patients? Well, at 5 years, if we look at just the endpoints of either death from breast cancer or having an invasive breast cancer recurrence anywhere, about 92% were free of that. So just to review, when we make a decision about radiation treatment after a mastectomy and where the person initially had chemotherapy or a combination of chemotherapy and other agents as their first intervention, and where the mastectomy and check of the lymph nodes shows no cancer whatsoever, it would appear from this study that even if the cancer at the outset was over 5 centimeters, as long as there wasn't ulceration of the skin, fixation of the deep chest wall, and as long as the amount of nodal involvement was relatively modest, typically 3 obvious involved nodes or less, that when there has been a complete and total response to the drug treatment, when the pathologist looks at the tissues, that radiation treatment is not needed. So I hope you found this presentation of new information somewhat informative. And if you have an appointment scheduled with me to discuss this or other matters related to radiation treatment, I look forward to your visit. Thanks for your interest.